having worked in the COVID-19 response for aged care in Victoria. Ann will be sharing her infectious prevention and control expertise and experience. Ann is a registered nurse of 24 years and has specialised in infection prevention and control for the last 16 years. Ann has experience in acute tertiary hospitals and community settings within Australia. Ann particularly enjoys roles in outbreak management and implementation of infection prevention programs in overseas countries such as Western Timor, Liberia, and Tanzania. Ann advises at a state, national, and international level in policy and safety programs. Ann is a board director for the Australasian College of Infection Prevention and Control. The college is the peak body for infection prevention and control professionals in the Australasian region. And as I said, it has been working in Victoria with the other COVID-19 response of aged care. And thank you, Ann, for your time tonight and sharing your experiences.
Thank you so much for that lovely welcome. And it's my pleasure to be speaking on this kind of forum. But I very much wanted this to be very kind of informal and practical approaches and experiences from so many of the staff within Victoria. And I think just so many of us would have been really quite excited towards the end of last year, thinking of the year of nurse and midwife as well. So hence the little logo down the bottom as well, just to kind of acknowledge this has really been a phenomenal year. So I would also like to begin by acknowledging the traditional custodians of the land for which we are gathered today and pay my respects to the elders past and present. I extend that respect to Aboriginal and Torres Strait Island people here today. Thank you. So I'll try to cover just the summary of my role, a little bit of background for the outbreak, but particularly about the barriers in aged care, the common challenges, some done and doffing kind of tips that we certainly learned along the way. The data that we actually collected, which I think is key really in that preparedness and moving forward. One of the challenging areas was with residents that were wondering and how we kind of supported those in those environments. Finish off with a little bit of an innovative teaching tool as well. So Tony kindly said a little bit about my experience, and certainly I have wore a few different hats and badges along the way, which I'm incredibly proud to be a registered nurse. And I had done some work in aged care when I was a student nurse in the UK, however, not as an IPC lead. And certainly this experience has been challenging, but also refreshing in opportunities to really improve and share with others as well. So the background, Victoria's second outbreak wave had a significant impact on aged care facilities. At one point, there were over, I think it was 250 facilities affected at any one time. The Commonwealth approached Healthcare Australia, which is an international agency, to see if they could recruit people rapidly, especially in the infection prevention field. There were many other organisations that came to support, from the Aged Care Commission, ACIPC, SPIN. There were a number of local hospitals as well within Victoria that deployed staff, and there were a number of interstate teams that actually came over as well. But my role was predominantly to really provide advice in line with the guidelines. So when I arrived, it was just at the beginning of July, which you can see the peak of it kind of occurring then, and that's when the lockdown occurred 12 weeks ago, which really summarised the wearing of face masks in public areas. Food supplies were the only stores open. Food you could get takeout from the restaurants. Exercise was 1 hour, and again there were a number of work restrictions on for people as well. So this was certainly my first time into having to wear a face mask, and for most of the day as well as going into the sites. But it's absolutely wonderful to see the decline in what's happening in Victoria in the last few days as well. So, as I said, the programme was supported by the Commonwealth. It was about going in and performing infection prevention assessments and to share knowledge with those within the aged care sites. We supported the Victorian Department of Health and Human Service guidelines, acknowledging it was a very much an evolving time, but these were the guidelines that people would be working with as we move forward. We were able to recruit registered nurses quite rapidly because of being part of an agency. There were nurses that wouldn't have been working maybe in surgical services. And I'll go through that model a little bit later. Essentially, we wanted to provide training with key areas within the aged care facilities to feed back to site leads, but also to partner with other agencies whenever we could. So the barriers to implementing infection prevention within the aged care. Aged care, they're not designed for infection prevention practices now. They're very much, homes. So that was a significant challenge. Initially, in the height, there's a lack of staff to support all the actions that were required to implement safe practice. There was the practicalities of when Victoria went into lockdown, not having the resources. So certainly it was, I think, about 4 or 5 days before click and collect came in when it came to Bunnings and office work. So, the practicality of actually printing posters or getting bins for all the waste and even laminating paper to put all the signs up was, again, incredibly challenging for sites. There had been a significant amount of work about the online training. However, there had been groups that they had actually adapted them, and that some of them may have been done from a national level and not actually in line with the state guidelines. So there was really some inconsistency in practices. And I think that probably would be for any state as well at this time as we kind of move forward. This was a brand new experience. There was no practical application with this kind of on this level. There was numerous teams entering to help, but there was all various different experiences, and each team may have their own state policies that they needed to support and adhere to as well. So that again made the environments very challenging, certainly in the larger aged care facilities. And as I said, people were not familiar with a number of the infection prevention practices in aged care. So if you can imagine, for most people, this would be your normal corridor for residents, and then suddenly say that we need to change it and put, donning and doffing stations in for outside every room, and then trying to suddenly convert your corridor, it's quite a dramatic change, especially if you haven't even heard of donning and doffing. And also then how your normal free corridor to walk down there has all these kind of tables and everything that can impede. So a number of practice changes actually occurs quite rapidly. The challenges, but the reality, again, social distancing. So many people done so much of their planning without trying to incorporate that social distancing. So if you think about you're going to meet your outbreak management team and they would always meet in one room, if you start putting PPE on and then start social distance 1.5, it became incredibly difficult. The new flows. So again, putting in different zones and adding new flows around. If you've always walked out your office and turned left to go around the corridor, then all of a sudden people are going to go right and down that another corridor. It was incredibly confusing. And then you have the lack of break areas. So if you zoned certain corridors off, you would need to then make a break room actually for those staff. So again, all of these things trying to put in place to really provide safe care and allow people just to have a drink as well. And some food was quite challenging in the early stages. The different PPE and the masks are certainly they're probably about a week, just over a week, and they changed from the surgical masks to the P2 and N95 masks. So again, it's trying to get people familiar and used to those. And again, people did initially kind of feel quite claustrophobic, although some people actually felt safer with that. There was very much a lot of the unknown really occurring. And really with the lockdown, it just the impact on everyone as individuals. So we all have our coping mechanisms. It might be spending time with family, it might be traveling, going walking, socializing, and that lockdown occurred. So all of our normal resilient kind of steps really for so many were kind of impacted on. And in some areas as well, this is just a photo of one area to try and reduce that flow for people kind of walking around and actually putting up a temporary wall actually with that as well, just because again, it was really quite a rapid changing environment and people didn't intentionally try to walk from a kind of a positive area to a negative area, but it was just trying to put things in place. And these are a number of really good innovations that really came from the staff in those areas. Then there's the emotions, that you can do all the training and have everybody prepped up for a potential kind of suspected or positive case. But if you're the individual sat in the office with that person who's positive, or you're the positive person as well, there's a lot of emotions that kind of come in those conversations early on, and how people try and concentrate with those. Also there'll be a number of staff that will be furlonged as well, and as they would be leaving, they'd be concerned about their colleagues, and certainly again with the residents. And there was no question there was a significant amount of media coverage. So I think all of us knew that once a positive case occurred in a residential care place, it could be significantly impacting. Then there'll be new staff come along, which would be absolutely fantastic, people coming to help, but then you need to give them an orientation. Each orientation could take up to an hour as well, and that's quite a big ask for somebody and a team to keep taking people through during that kind of phases as well. There's no question infection prevention guidelines have evolved over the last say year with COVID, and certainly this was obviously brand new within aged care, and certainly again in the world of international COVID as well. Also, I'd like to just say wearing PPE is a learned skill. It's not something that you can necessarily just learn online. It's something that you have to kind of practice with as well. Some other challenges were the equipment. Did you have enough equipment to do blood pressures on all the residents at any one time? When we made a donning station, sometimes that'd be the only space that people could put things on, so the crossover contaminated with cleaner as well. When we couldn't get the bins, the innovation where laundry skips fitted a waste bath superbly. So again, to try and support those in those early stages for safe kind of donning and doffing. So I just really listed good time to step into the program. So even though there was a call that went out nationally for infection prevention nurses on really day one when I arrived, there were just 2 of us. And even though we had no colleagues within in Victoria, as you can imagine, it's a very specialised subject, and trying to be in a resource is quite difficult really within the organisation. So we quite rapidly realised that we needed to develop and kind of train people who could just support. So we looked at registered nurses that had 4 years more experience, individuals that would be confident in having a conversation with the donning doffing, but importantly, if somebody was going to breach and there was a potential risk, that they would be able to speak up and take people through that calmly as well. So these weren't necessarily infection prevention nurses, these were just experienced registered nurses, and they would focus on the donning doffing training within the state guidelines, and the monitoring of the hand rub and the PPE and the posters that were up in place, and just kind of general questions, so really basic questions. And then myself and my colleague would then support those with site visits and then be on the end of the phone. And you can see from photo there's some of the fabulous team. Also, we again developed posters and signage, because again, this is something that we were able to do that within the office, and we had staff in the office that could actually help with that. So when we got to a site, if they didn't have the signage, we could just pass it to them and help them actually even put it up, to do some practical sessions, and then be able to support with some RNs as well. So moving really with that model, just really want to highlight about the personal protective equipment. So again, this is not a new process. So I've been teaching this process for 16 years. However, it certainly at the beginning of the year seemed incredibly new to the kind of a number of the workforce. And I think with the added stress and certainly what's happening around the end of the rest of the world was significant. So when I arrived in Victoria, there was this kind of increase with healthcare workers being affected with COVID. And there was this kind of unknown of really what was happening and what was occurring. But again, we did realise quite soon that really the online training, people didn't actually have the practical application. It was just seeing what they'd actually done. So I think a number of assumptions were made that people, when they'd done their online training, they didn't actually remember the process, that they would actually even be confident at actually putting the PPE on and off as well. The training doesn't capture maybe some anxiety that you may feel. So certainly if you're anxious and you're putting the PPE on and you don't get your mask up or your visor, you may steam up quite quickly. And certainly there were times when I had my glasses on, I'd steam up because I just didn't feel comfortable. Now I'd easily go and doff and come back and do it again. But if people didn't really understand maybe their own kind of anxieties may increase, kind of the heats around your face, and you can mist up easier. So again, it's about trying to reduce that and making sure people are comfortable with that. So, and I think this went on for a number of days, and we realised this was a significant gap. So we really just really linked into what was occurring in the States. And I would say on a national level, Victoria's posters are probably the most simplistic in the steps and with the writing on. And it just having the same poster and talking the same procedure, it just reduced the inconsistencies. And at that time, there were a number of other posters coming out. People were printing off from national kind of groups. And however, it was really important that we maintain the state so that we could all support safety and know the same process. So, and that's important when somebody is actually putting PPE on or removing it, and you can actually support them because you know the process with that. And if people have different processes, it's very difficult to kind of keep people safe that way. And for some reason in nursing, we often print in A4 and laminate in A4. I know in a number of places you don't necessarily have colour now, but again, on reflection, it was far easier to print in A3 and have that laminated on the wall as well, because again, you can imagine with having the PP on and the doffing, it's far easier. And a lot of posters have a lot of writing on, when really you just needed the pictures. And certainly for a large percentage of the workforce where English isn't the first language, you know, again, it was hugely helpful with these posters. So again, the training was really very much about familiarising people with it and just going through that consistently train, always pointing at it, to know when to perform a hand rub correctly, because again, some people either do too much or they wouldn't actually do any at all. And I think I want to home in on this is because I think people don't realise this, that when there was a positive case, you know, there were some sites that lost 50 to 80% of their workforce within the first few days. So you've got multiple agencies kind of coming through, and that we would see that quite there when we're on day 4 and 5, and different people coming in and different processes in. So you can never underestimate the ongoing support required with the donning and the practical sessions at the time, which I'll come to a bit later as well. And trying to people. Certainly I come from a tertiary site where we'd always talk about a spotter or a buddy to help you with your donning and doffing. And really in this environment in the early stages, there weren't staff available. However, there in aged care facilities, there are a number of mirrors that are actually around. So again, we was trying to teach people that actually when you actually don, if you look in the mirror, you can actually see that if your mask is straight and your straps are nice and straight and your visor straight, then it's a little bit of reinforcement as well. So it did take people a little bit of use to get used to that, but certainly it's an excellent way to encourage that safety. And some of the common gaps really when the people breached, people talking to each other when they're kind of, you know, during the procedure, and they just that lack of concentration. People are incredibly tired, and when you come out and you're hot, that urge to take your face shield off and your mask off first is, you know, was very evident in the early stages. Hand rub on the gloves. So again, you know, multiple times having to people there, but it was incredibly difficult when they'd see some other people do it and then they would just carry on and do that as well. And the hand hygiene on the doffing as well, you know, either there wasn't enough kind of hand sanitizer there, or people just had that urge to remove the PPE. The gowns, to try and make sure they were covered around people's backs, and how people just would put them on or have them off the shoulder, or just not really comfortable as well. So just reminding people about making sure it's comfortable. Certainly, as I said, the N95 P2 came in very rapidly, and it was very much about the fit check. So it's just trying to have that one poster and just to remind people every time to put the mask on. And to make sure, I said, the ties and straps are comfortable, so you're not going back and touching around by your head and face at the time. Certainly, when the PP changed colour, you know, that did again result in some uneasiness because people maybe weren't familiar, thinking it's not the same, and then therefore it's actually trying to kind of retrain people as well with that. And certainly donning and doffing stations, they tend to be areas people would collect on as well. So to actually have areas where people can actually put stuff on as well as that and keep those areas clean, it was very important. But you know, you can actually see it's human nature just to, when you see a space, to actually put it on. So really with some practical sessions, and advice really, if you can imagine workforce not knowing what a donning station looks like, but having one set up where you take a photo and just say, you know, if anything happens, this is how I want your donning station to look like. You know, so it's a good visual tool, and that everybody will understand. Trying to explain that through. You know, the use of coloured tape was incredibly powerful. I mean, not only because you kind of set the scene and expectation that is where you wanted your station, so it didn't move, but also it's a very good visual prompt. Now, people use different colours because red and green didn't last because, you know, the tape, so it may be blue or yellow. But essentially, you know, you can see the green there. It's very visible, and essentially it's where the clean PP is actually available. But also do remember that you may need more stations where people actually don as well. Because again, if you get multiple staff, you lose that social distancing. And again, it's really important people don't feel rushed putting that the PPE on. The doffing, again, this was you know, really quite difficult to kind of teach people to do this slowly. And you saw multiple kind of breaches in the early stages. So really just came out with some simple steps so that when people went into a room, that they actually knew the area where they would be able to doff the PPE, and to make sure it actually had the correct equipment on their units, especially the hand and gel. Again, as you can see, we use red tape here and the red sign again to make it nice and easy for people. But in those early stages, it was very difficult teaching PPE, socially distanced, trying to get a quick message across in 5 minutes. So I had done this previously in other parts of the world, and so we purchased some children's paint. And again, it was a very powerful visual aid, because we couldn't necessarily take lots of staff outside to try and train. It was very much kind of in the environment. So we just put the paint on our gloves and just say, imagine this is COVID, and you've gone in the room and you've touched around your face. And it just seemed to really kind of get people engaged. They were kind of really brought it to life for something that we cannot see. So again, just trying to remove the gloves off slowly and not get the paint on you. And then we would do the teaching with that. And that was really successful in the short time frame, socially distanced, and again with the different languages as well. And we're trying to encourage, again, the trainer with those sessions. So again, to make things nice and easy as well. So even though I'd said Victoria, I found that their posters are getting far easier than others I've seen. But again, they do look quite similar, the steps. So again, just having a poster above, kind of darning, a red poster with feather doffing was really, again, very helpful for people when they came out. So you didn't get that cross-contamination of the stations. My own resilience, certainly over the years, you know, it's incredibly important that, you know, I was aware that I was there on a 12-week deployment. And even though I had experience in outbreak situations, and I have 16 years experience, I was, you know, quite conscious that the demand on myself, and I really needed to be productive and sustainable for those 12 weeks. So certainly connecting with my family and friends was incredibly important. Just be able to speak with them regularly. I made a little wall in my apartment, as you can see, of just different post-it pictures of my family and my favourite things as well. So certainly, again, that was a reminder of just to kind of, you know, a little bit about who I was. I did get some packages sent through, although they were a bit slow, but that was a lovely surprise. The walking and the outdoors is something that's I do quite regularly. The challenge with the lockdown was there, but it was just trying to get that balance. And I think just a combination of those certainly supported me through the 12 weeks. Although I must say I did miss smiles. With everybody wearing masks, I miss that connection and the smiles. And certainly arriving back in Western Australia yesterday, it's quite confronting to see everybody's faces. So. But I think it was really important I took that journey along the 12 weeks. So the data really that we captured over the first 8 weeks. So it was from 26 sites, and there were 43 assessments, which really captured the major principles of what was needed in a residential care facility. And most of them, really 85%, the first positive case was actually from a staff member, which I think is important to know when you've got lots of community transmission, that it is that the staff member kind of you know, coming up positive, and often they're not necessarily having the symptoms. with that just multiple screening. When we enter sites, the setup time, and even though a lot of the guidelines say to be able to set up within 24 hours, if you can imagine being in a 200 bed residential care home and trying to fit on and doffing stations throughout is significant, and then losing 50 to 80% of your staff in the first few days, you can see why it took a number of days to try and get these the setup in place. And that's not to say it's been embedded, so that's just the kind of around those initial setups. And just one caption is that we had one site. It was about 70 beds, and I actually asked the staff to capture how many competencies they were actually doing for all the different staff. So again, we would train any agency staff member, any staff member really within the organisation, because it's about everybody working together for safety. And actually within 2 weeks, the two staff had done 120 competency audits, which was a phenomenal number, which I actually thought. And we did develop a Don and Doffel audit tool because we felt that we're trying to capture safety and trying to do quality improvement. However, just really we've probably done over 1,000 now of those audits. The reality is when you actually saw somebody that was going to breach and potentially be at risk, you stepped in. You didn't carry on as an auditor actually with that. So yeah, I think the data is not really represented here, but did it act as a safety tool? Did it provide a consistency for people within the area? Yes, it did. So the gaps really were captured at the time. Just some further information, really, the registered nurses would have to send in a report every day as well. And there's kind of the top three things that really kind of came out every time was confusion when the workflow or the zones changed. And even though it might seem quite simplistic, or, now we can step down and we can do this step, or we can move this over here. Again, with the multitude of different staff and trying to get that communication over was very difficult. And certainly people felt that the guidelines being changed and that it just made things kind of a little bit uneasy for some people as well. So again, that's really important, I think, when changes are, to how to effectively get that information across, again, a number of agency staff that kind of come in as well. The PPE not being worn correctly, and then also people touching around the face and mask continuously. So again, how do we kind of reduce that? Is that about people learning about how to wear the mask more effectively, trying to kind of subconsciously teach yourself not to keep touching regular blades maybe, I'm not sure, but again, that's certainly a target area for improvement. And really the first 2 to 3 weeks are the most challenging in trying to establish practice, and that's probably because of the different number of agency staff that are kind of coming in and actually supporting and not having the permanent staff. And I've said to week 3 and then into 4, the permanent staff normally start to actually return. So, but obviously a lot of number of safety changes would be in place, but these are the common factors. And as you can imagine, this was a photo for some of the team, and I think you can guess when that was actually taken. So I'm quite surprised they have this much energy, but it's but certainly a lot has been achieved. So I'll quickly just try and capture what has come up in so many different forums about the caring for the wandering residents. And I think for me is that these are very much individuals, and their needs vary and their care actually varies. And normally they have a skilled set of staff who provide support and quality to their lives. Also, again, knowing the individual, but their families as well. And of course, when a resident place goes into lockdown, those things are actually kind of, lost, which is hugely impacting. The infrastructure of the buildings as well, that they, care and safety is that the residents may be in a contained or secure area. They may have some outdoor areas. They might have been mixed and not be in a kind of secure area, and they might have shared corridors with other residents as well. And then there's the different size room, and I said some of the memory care units had shared rooms as well. So, the infrastructure in the buildings, was supported safe care, but then it was really difficult, challenging other factors as well. There's often specialised furniture, and as I said, people that normally provide programmes and activities daily for these residents. The challenge in the outbreak when it really is that when you have somebody turn up in full PPE, it can be really confronting. And I can only imagine, maybe say, if I'm sat in my lounge with my family and somebody walks in PPE, really, I'd be confused. I'd be kind of what's wearing and very concerned with what's going on. So again, it's it's how you can try and manage those. You also lose the ability, that people can't see your face. They can't see if you're smiling. They may not even be able to hear you, correctly through that PPE as well. So, you can see these little steps now kind of building an area that may already be stressed at the time, changing their patterns and routines, and certainly a number of staff going in that are not familiar with these routines and their individual needs. And as I said, so often in these areas, there's so much care and love and attention, and that's really was removed with the outbreak and the PPE. So the lack of the skilled staff, for these individuals, but there was a lot of steps actually put in about communication and trying to be able to link in with families as best as possible, and trying to capture what their favourite things actually were. The moving of residents was certainly, I'll go back, sorry, I'll keep that one there. The moving of residents certainly increased, the confusion, distress and delirium, and I can only, now that it's kind of popped up again, the more I think, the more confused I can become with any change of environments and change of processes. So you can imagine if for this special group of people that, all of these things kind of actually adding on as well. And then there was the lack of space. So often so many of these care homes, that they're normal dining areas or other areas that would need to be used for actually storing of PPE. So obviously you would want to reduce the amount of mixing, but again, there's a lack of space really just for the simple storage, and this would normally be a lounge and is now kind of an area for PPE. So the potential solutions, really, the Commissioner had a fantastic chart that really kind of helped guide people during that kind of phase, and to certainly start conversations between teams, to declutter areas as well. But also we did find that putting kind of crosses on certain marks in the areas, in some areas, and popping a chair there and keeping social distancing. So someone in residence, they could actually sit down and feel a bit more relaxed and kind of get that little bit of kind of freedom as well. Behaviour charts and the shift daily assessments and the COVID assessments as well were really pinnacle to kind of supporting their safety and journey. So again, as it kind of evolved, really, it's about trying to have activities in those areas that people can, with wipeable equipment, encouraging hand hygiene. So again, I think this wasn't utilised early on, that actually a number of residents actually can and would be willing with the hand hygiene, and a number of them did actually wear masks, so they weren't all opposed to wearing masks, increasing the connection with families, and really only consider transferring out if for a safer environment if absolutely necessary. So I'm just coming up to the last few slides, really, just to say about outbreak management plans, and really for kind of any sites really out there. Certainly there is the interim report from the Commission, which has some really good recommendations, but again, some items really to consider in your planning. And I would actually ask for people who've spent time writing a COVID management plan, normally feel quite exhausted after it, but again, it's really about, has it been reviewed, has it been tested, and really are the whole team actually aware. And I just really want to show you just one way that you can actually bring your outbreak management plan alive by just creating a situation board. So just a simple board that you would maybe have in the middle, and again with your site on there, but certainly again it can vary different sites, but an area that people can look at and discuss, particularly where you can empower other people. So certainly you could just have a scenario just on the left hand side of when a positive comes through. You can just have, what would ask the team, what would they do if there's that one positive? How would they move? Where would they zone? How would they kind of coordinate where things would actually go? And I think a lot of your answers will come from your team. They will be able to say, kind of give solutions with that. And it brings the plan alive from a folder up to a kind of a board. And then you can actually maybe write some actions down of which person will be best to do in what situation. And then develop from those action cards, similar to like business continuity, that then people just have those cards and not trying to go to a file. So just I've done some teaching with this previously in other outbreaks, and but it just is that engagement and trying to empower a workforce really with those conversations is incredibly important. So really just to finish on the last few slides here is that I can remember developing this poster for my line manager and just saying that infection management can be exhausting, but we have to keep at it, because battling outbreak is so much worse. And it's certainly, I think Victoria's experience, as so many people have seen, would have been incredibly challenging. And just really my reflection, as I said, with the experience that I have, that really what occurred in Victoria was groundbreaking, rapidly placing infection prevention control in people's homes, communal living, whilst potentially furloughing staff. Often those left were fearful of the unknown and what could occur to themselves, their colleagues, and residents for which they may have known for years. And that was hugely impacting when their staff had to leave, and they felt they were leaving people that they'd known and loved for years as well. But we are turning the corner, and a huge amount of work actually has been done. So, I just want to go back. I do apologise. Previous. So, as I said, I am a board director for the Australasian Infection Prevention Control, and I just really wanted to just flag this in the sense that anybody can actually join. It's such a diverse group, and it's a body of foundation courses for infection prevention. But I think for me, if anybody's feeling kind of isolated or they don't know how to connect, you can see there's a number of different professions that are within this group. So I do strongly say have a look at the website and see if anything's interesting. There are some free webinars there for you. Okay, so now it's not going to work properly now. Here we go. No, I do apologise. So I'd like to acknowledge the work and the courage of so many who supported Frontline and afar. I'm very grateful, and certainly this is an opportunity to try and engage people, empower them, and certainly inspire people with this experience. Again, considering the year of the nurses, certainly there have been some absolutely outstanding nurse and midwifery leaders along the way. And as an infection prevention expert, I wouldn't normally encourage the word of contagious, but in this aspect, I do think as we move forward, let kindness be contagious. Any questions?
Thanks, Anne. Thank you for your time. A great presentation to listen to. Now, we do have a number of questions online, and I will try and group some of them together. One of the questions was around student nurses on clinical placements and the ability to support the RN in following IPC strategies. And can student nurses, and the other question was, can the student nurses join the Australian College of Infection Prevention Control?
So just absolutely student nurses can be a part of that. Certainly, even though we use registered nurses, I do feel that the model that we went with, we just needed people to feel confident and comfortable in speaking up for safety. So that if somebody actually wasn't putting the PPE on correctly or taken off, or the area wasn't being tidy, it's about people kind of just talking, saying, look, we need to keep each other safe. Let's remind each other on that. So it's about people who can have the conversation. And certainly my experience within the aged care homes there, it's not just RNs that were outstanding. There are a number of other professions there that people that would actually speak up, and certainly had some fantastic partnerships with some of our cleaning workforce as well, because they understood the risks. I hope that answers the question.
Thanks, Anne. One of the other questions came up was around, is the IPC strategy applied in every healthcare facility, or only areas where healthcare professionals are exposed to COVID patients?
This was just purely as a response to the Victorian outbreak, and this is what we from Healthcare Australia implemented, and because we had access to registered nurses quite quickly. But I know there was other models that were brought in Victoria involving other allied health staff as well that were weren't actually working. So it's a kind of a similar model to them, but we were able to get to there, and that nurses there on night shift as well. So that kind of covered that gap as well.
Thanks, Anne. I've just got a practical question that's come in, and it's talking about the tea room that most nurses love. In the tea rooms, how to reduce the risk of transmission when staff take off masks to eat or drink.
So certainly some staff rooms that, maybe only have 2 people in, they would have a sign in, sign out log sheet. Some areas they would have outdoor areas for people to actually utilise. Some use small marquees. Up in the initial stages, some people would just go and sit in their car, which is maybe not necessarily practical, but again, in those early stages, people would try to reduce. But I think it was the staggering of breaks and having the sign in and sign out login sheet, which kind of was beneficial. But in the early days, when there's not any spare rooms, it's incredibly difficult. And that's why I would say in your preparedness, if you think that actually you've got like 3 or 4 wings and you think actually wants different entrances and different staff in those areas, how do we actually support with those breaks? Because, if you're wearing that PPE, you'll encourage people to have breaks more often. And it's very difficult when they don't have places to actually go. So having those conversations early on is really important.
Thanks, Anne. Another question that's come in is, are there any alternatives to wearing the mask for healthcare professionals who have developed anxiety or feel claustrophobic due to the long hours of wearing protective masks while on shift? Not
that I've read or seen. My concern with people who are anxious and not feeling comfortable in the mask, then they are very at risk of reaching because they'll continuously go to touch. And I certainly would say maybe to not use them in that area if possible, because you can't guarantee their safety. And certainly in the aged care sector, when they're in the early stages, when you may have the one positive case, but you're not sure how far it's spread. Potentially everybody is suspected, and it's incredibly difficult. So I think for the first couple of weeks, if you can maybe not have that staff member in those areas for their safety, I think that's far best.
Thanks, Anne. There's a question around cleaning in residential aged care facilities, and were the common areas disinfected on a regular or daily basis so as to prevent transmission of COVID to healthcare workers?
Yes, they were. You would try to reduce all the common areas really, so the residents wouldn't go to those areas. It was only maybe, when you had wandering residents that you may have to utilise that for safety. And it's about having those cleaning programs actually in place. So you would only have a staff that would go around and do 1 or 2 cleans a day, and then you have people in high touch areas every couple of hours walking around. So those policies did kind of evolve, but it'd be important to declutter. I have to say nurses stations are terrible, and I would strongly encourage everybody to go back to there now to actually declutter, because you cannot clean effectively with a lot of equipment actually around. So it wasn't uncommon for shipping containers to be ordered and that actually extra furniture be put in those containers, or in the early stages like tarpaulin, furniture was put outside and it was just covered over as well, so to actually allow for all of the space.
Thanks, Anne. And just in your experience, one of the questions that's come up is around with staff wearing masks or PPE for a long time. Did you come across any of the staff that may have developed allergies to the PPE?
I didn't actually meet anybody, but we did hear about staff with some of the masks getting quite sore nose with them, and then some people again feeling quite itchy underneath them. But our advice was really consistent really from the Department of Health, is that you can't really keep those staff safe if they're going to be again kind of touching around their faces. During the outbreak, it was quite difficult to try and get alternative masks, so a lot of masks did come around from the Commonwealth. But I think that now there is a different form, so you do have more time now to, if it's a specific mask, then can you actually get alternative masks actually for them? But obviously that's something moving forward.
Thanks, Anne. And I'll ask another question if that's all right. Did staff change clothes before leaving for home at the end of the shift?
that was the advice from the Department of Health, and certainly we would strongly encourage that. So changing areas were a bit, again, limited, but so staff could come in with no uniform, and they would just have clothes that they could actually then change in when they actually left home. But yeah, that's something really was supported right from the start.
And the last question, and it's up here, is with the introduction of the IPC strategies, do you believe the desired results would achieve, and would you do anything differently?
I think, I mean, certainly to be able to empower more people with the IPC person in, so that more of a trainer-trainer model would be more desirable, having more in-house kind of connections. But that's very difficult when you've got so many different staff being furlonged. So I don't know if moving forward that I would maybe try and engage with different agencies that maybe be deploying staff to them to empower them slightly more. That, you know, it is very much a team effort when you go to an outbreak. This is not a hierarchical process. I mean, certainly sometimes I'd be incredibly tired, and people would just remind me about you know, my doffing, and you know, I'm forever grateful because I want to come home to my husband and children safely. So I think to empower other people in those processes, it is an outbreak, would be really beneficial. I think the experienced RNs do offer those skills with the communication. But I think, and I think that there was a lot of people missed, like GPs and some of the living support staff and some other agencies that came in, and they actually hadn't been exposed to any of that kind of donning and doffing as well. So it's very difficult to maybe go and approach somebody you don't know and actually try and advise them of what the correct processes are as well. So, you know, it's really that speaking up for safety conversation, and I do believe you can empower a number of people with that, not just say RNs.
Thanks, Anne. And I will, there's a late question. This will be the last question for you. That's all right. What would be your personal tip to student nurses who will be entering the workforce during the pandemic period in terms of transitioning from a student to a registered nurse?
I just think that when you become a registered nurse, for some reason you forget all of the years of training that you've got. I mean, you're a registered nurse because of all the training you've got, and you should be incredibly proud that you're at that stage and that you do actually have a voice and you have a freshness to this. So I find that newly qualified nurses, they kind of are more supportive of the guidelines and very close to the guidelines, and you should absolutely be listened to. So please don't underestimate the role in safety that you can actually provide.
And just one of the comments came in there. Are you comfortable to share your presentation?
I am.
And
sorry, I got the slides wrong towards the end, but yes, yeah, absolutely.
That would be great. So we'll organise it through the Australian College around that. So thank you for your time, Anne. That was a great presentation. I'm sure everyone who's online have learned something from it. And also thank you for putting yourself out there and going over to support our colleagues in Victoria. And we're glad you're home safely.
Thank you so much. It's been a privilege to present this evening. Thank you.
That's great. Just before we wind up on the webinar this evening,